Oh, I got out of the way. What'd you say? Yeah. Come on. 30 minutes since we had that.
Congratulations, Sarah. Very well deserved.
You too.
Yeah, I did get something, didn't I? I actually need to talk to Coach Cunningham. Project. And good morning, everyone. It is May 7th, 2021. Boy, Zoom slows this thing down something fierce. Well, it's time to start, and it looks like we have a skeleton crew today. Baseball, as far as I know, they had to reschedule, I think, due to inclement weather, which, given the weather we've been having, frankly, when I saw Mr. Mrs., whatever, sun shining through today, I was shocked. Because the forecast said, quote unquote, generally crummy weather for the rest of the week. So, and given how cold it is out there, I said for sure there will be no sun. But hey, we have sun. I'm not complaining. So there we are. Okay, so we were talking about the drugs that are used to treat diabetes. We talked a bit about how they work. Now let's talk about how to use them. Let's talk about the caveats that come with using them. Caveat, by the way, comes from the Latin, which means to beware. So these would be things to be concerned about, side effects, things you should watch, what have you. And then we will do our best to finish this. And we are going to have a review session for the final. I think it's on Tuesday. We agreed Tuesday evening. We have to figure out where. I think I can get a room in Whiteman Gibbs. Let me see about getting a room, and then I will get back to you. All right, Greg? The Zoom isn't on. If that's not Zoom being on, I don't know what it is. Does he not have the right URL, maybe? I'm not there? Well, clearly I am. I did. It's on Blackboard. I don't know what to do because it's clearly on. Doesn't look like I posted it. Okay. Copy invitation. Okay. There, hit it several times. So copied it. All right. Are you seeing what I'm seeing? May 7th? No? You don't see May 7th. Okay, can you read May 7th up there? That is right now. That's on my blackboard right now. Okay, then here's what we'll do. You will, huh? Okay, there it is. Tell me, come on in. All right. Hopefully folks will come in and all will be well. Okay. So type 1, as we said, tends to occur in type 1 diabetes, mellitus, tends to occur in younger patients. The onset tends to be acute, although the destruction of the beta cells is gradual. Tends to be an autoimmune disease. It can be induced by trauma to the pancreas. It can be induced by viral infections that affect the pancreas. It can be induced by just the immune system all of a sudden having a lean and hungry look at beta cells and destroying them. It can occur very young in childhood, as young as 3, 4, 5 years old. It can occur in adolescence. It can occur as a young adult. It can even occur as a middle-aged adult. But the result is the same. The beta cells are destroyed. You don't make enough insulin. You need to inject yourself with insulin. That's type 1 diabetes. Type 2 tends to be a gradual onset, tends to be linked with obesity. Reason being is that fat cells are actually endocrinologically active. So these cells secrete adipokines. This is quite pathetic. Those adipokines come into 2 categories. There's some that promote insulin sensitivity. There are others that promote insulin resistance. When fat cells are relatively small, and there's not very many of them, insulin sensitivity predominates. When fat cells get big, and you have too many of them, insulin resistance will now predominate. So in the obese individual, the insulin resistance promoting adipokines predominate, and you lose sensitivity to insulin around peripheral tissues, and now you have insulin resistance. And that is the hallmark of type 2 diabetes mellitus, is insulin resistance. In elderly patients, sometimes you get beta cells that get worn out. So very often in elderly patients, it might be asymptomatic. You might have weakness, unexplained weight loss, changes in vision, frequent infections, long-term complications, changes in mental status. These are things that are associated with aging anyway. That's why it can be missed. The way, of course, you would diagnose this is with an oral glucose tolerance test, an oral glucose tolerance test. So as you can see here, the amount of glucose that gets released into the bloodstream is very, very high. This leads to hyperglycemia. That's a hallmark of diabetes. Now, those numbers we reviewed last time, between 65 and 105 milligrams per deciliter. That's the fasting glucose, that's the range of fasting glucose concentrations for people who do not have diabetes mellitus. Those numbers I need you to remember, between 65 and 105 milligrams per deciliter. If you're above that, you are in the pre-diabetic zone, but if you're below 125, you're still in the pre-diabetic zone. If you're at or above 125 milligrams per deciliter for fasting blood glucose, you're diabetic. So here are the clinical signs of diabetes, the 3 Ps, polydipsia, polyuria, polyphagia. Polydipsia, polyuria, polyphagia, constantly hungry, constantly eating, constantly thirsty, constantly drinking, and because you're constantly drinking, you're constantly urinating. The 3 Ps. Then there's also fatigue, dry skin, blurred vision. But the 3 Ps are the hallmark, and then the lab result would be hyperglycemia. So long-term complications of diabetes include diabetes vascularitis, because the vasculature is under a constant state of inflammation. This causes the vasculature to thicken, but also become leaky. That's kind of contradictory, but it is the case. It thickens, but it leaks, and it leaks chronically, leading to edema, leading to tissue inflammation, and so on and so forth. Probably no tissue in the body depends more upon microvasculature than the kidney. So diabetic nephropathy is also a long-term complication, as is diabetic cardiomyopathy. Once again, a tissue that depends on very delicate vasculature in order to feed the cardiomyocytes. Damage to peripheral nerves will cause diabetic neuropathy, which is first felt in the feet, the bottom of the feet. Now that's different than what you see in runners. So runners very often will have kind of a dead zone at the bottom of their feet. So if you take the foot and you say stroke the instep, most people, if you stroke the instep, the foot will do this. Runners, because they'll have kind of a dead zone, you stroke the foot and the foot does nothing. The way you tell the difference is by the toes. If you take a tuning fork and you whack it on the, don't whack your patient, whack the table and then put the tuning fork on the toe, they should be able to feel the vibration. So it's the deep vibration feeling. Runners should still have that. People with diabetic neuropathy will not. So that's one of the ways you distinguish between diabetic neuropathy and runner's foot. and then diabetic retinopathy. Diabetic retinopathy. Again, in the retina, you get thickening of cells in the vasculature, but the vasculature becomes leaky, causing the retina to swell and causing changes in vision. So diabetic vascularitis, diabetic nephropathy, diabetic cardiopathy, diabetic neuropathy, and diabetic retinopathy. Those are the 5 main long-term complications of diabetes mellitus. Now let me just say, if you treat diabetes and control your glucose well, you can stave these off for a very long time. I tell the story often, but I'll tell it again. Bill McMillan, a retired engineer from Consumers who sang in the Jackson Chorale with me for years, is 85 years old. He's been a type 1 diabetic since he was 17. He still has complete feeling in his feet. Bill never has a blood sugar above 200, and he has a wife that nags him endlessly. That's why his blood sugar is so good, because his wife just nags the crumbs out of it. But it keeps him healthy. So, if on an oral glucose tolerance test, you break 200, or if you have a casual glucose concentration of 200 or more milligrams per deciliter, or if your fasting blood glucose is 126 mg per deciliter or above, you merit a diagnosis of diabetes mellitus. So the goals for your glucose essentially for diabetics. So this is the American Diabetic Association categories for fasting glucose. So a normal fasting glucose should be below 100 mg per deciliter. An impaired fasting glucose would be 100 or above. Many clinicians will say 105, but if you're above 100, they'll usually want you to be careful. And if you have a fasting glucose, this is again an 8-hour fast, an 8-hour fast. If you have a blood glucose, fasting blood glucose of 126 mg per deciliter or more, you are diabetic. So who should be screened for diabetes? Anybody 45 years old or above? And when you go get your physical, you get your blood drawn, getting your blood sugar taken, that's essentially the screen. So when you went to your last physical, you got your labs back, there was a blood sugar in there, the lab tech or the healthcare administrator may not have reported it to you, but there was in there. Usually if it's normal, they won't say anything to you, but sometimes they will. Also, test anyone younger than 45 years of age if they are obese. That would be a BMI of above 25. Anyone with a first-degree relative with diabetes mellitus, type 1 or type 2. Anyone who is in a high-risk ethnic group. High-risk ethnic groups include Latin Americans, African Americans, and Pacific Islanders. Those 3 groups are high-risk groups. African Americans, Latin Americans, and Pacific Islanders. Also, if a young lady has given birth to a baby over 9 pounds. Oh, that's a big kid. Or if they've had gestational diabetes, they should be screened because women who experience gestational diabetes have a clear increased risk for developing type 2 diabetes. And then anyone with hypertension should also be screened for diabetes. Oh, Native Americans too. Native Americans are also at high risk. So for diabetic patients, the goals for their blood sugars are preprandial. Prandial means taking a meal, eating. So preprandial would be before you have a meal, before you eat. Preprandial blood sugar should be between 80 and 120 mg per deciliter. That's a goal. If you don't meet your goal, oh well, there'll be other times to meet that goal. That's what you're shooting for. Bedtime glucose between 100 to 140 mg per deciliter. Then we have this measurement called the A1C. What is that? Sugar is a very energetic molecule. It's very reactive. That's why when you have lots of sugar in your bloodstream, it's very bad for your tissues because that sugar goes off half-cocked and just starts reacting with things. Did you ever wonder how the bread got its crust? Anybody know? What's bread? What's bread made from? Bread dough. Bread dough is made with flour. Flour is largely starch. Starch is a polymer of glucose. So, how do you make bread? A little bit of this, a little bit of that. Made the bejeebers out of it. Make a loaf, put it in the oven. What do ovens do? They heat them. You heat the dough reacts with proteins in the flour. It derivatizes them. That's what causes the crust. That's what sugar does to your tissues after a long period of time. It derivatizes them, it cross-links them, and it destroys them. So, how do you measure the amount of damage glucose is doing to your tissues? You use hemoglobin, because glucose will attack hemoglobin and attach to it. That's called glycated hemoglobin. Glycated hemoglobin. Otherwise known as the hemoglobin A1C. So it's reported as a percentage, the percent of the hemoglobin that is glycated. In a non-diabetic, that number is usually not higher than 3%. You want your diabetic to be below 7%. The A1C is typically a number that expresses the quality of the long-term control the patient has. They have good long-term control, their A1C tends to be lower. They have poor glycemic control, their A1C tends to be higher. Now, with the advent of constant glucose monitors, A1C is starting to fall from favor. It's being used less and less because of the presence of constant glucose monitors, where you take essentially a medical chip, you insert it into your sub-Q, paste it to your skin. It can be unobtrusively placed on the back of your arm, on the side of your body, wherever. That gives you a constant readout of your blood glucose level. That is a better measure than A1C. So A1C is starting to be used less and less, but it's still used for now. All right, so the treatment for type 1 diabetes is they have to take insulin. For type 2, they're going to take medication that will sensitize tissues to insulin. Notice, in both types of diabetes, you must have diet and exercise. Again, exercise is a known sensitizer to insulin. And something as simple as going for a walk can actually improve your use of sugar, your efficiency of your body to insulin. And in the United Kingdom, in England, doctors will actually write the following prescription for diabetics. Get a dog. I'm not kidding. Because it's very easy to go to the RSPC and pick up a dog. Also, dogs need to be walked. In fact, dogs often need to be walked twice a day. So it forces you to take a walk. Now, American doctors probably wouldn't do that, but British doctors feel completely fine saying, get a dog. Oddball statistic. British families spend more on pet food than they do on children. I find that really amusing. But when you go to England, a lot of people have dogs. People are walking dogs all over the place. And they don't always pick up after their dogs, too. And if you don't, you can get a hefty fine if you're caught. Some people around here I wish would get a hefty fine. All right, so your nutrition for the type 1 diabetic has to have sufficient carbohydrates to match the peak of their insulin. If they're using rapid acting insulin, that peak will usually be about 2 hours. It will start working 20 to 30 minutes after you take it, and the peak will be about an hour to 2 hours after you take it. That's why you take the shot before you eat, not when you take your first bite. You must schedule meals regularly, and you want to try to limit the big swings in glucose concentrations in your blood. That can be hard to do, but you want to try. And some diabetics have very good control, some don't. That's just the way it goes. In kids, you want to try to maintain normal growth and development. For type 2 diabetics, it's very important not only that you achieve optimal glucose levels, but also that you achieve cholesterol and lipid levels that are healthy. Your LDL must be at or below 100, and that they maintain a normal blood pressure. And the old clinician trick is if someone's a diabetic, when you take their blood pressure, in your head, you add 10 to their systolic blood pressure. You want to try to achieve and maintain weight loss goals. That's going to be hard because, as we'll see, some drugs are going to promote weight gain. Now, some will promote weight loss, but some will promote weight gain. That's going to be tough. Increase physical activity. Again, with this, increase it gradually. You don't have to increase it, marathons all of a sudden, no. Increase it gradually. And watch the types of foods that are consumed and the quantity of foods that are consumed, because it turns out people are extremely good at overestimating the amount that they eat. All right, getting back to our medication. So we have the insulin secretagogues, sulfonylureas, mellitus, things like that. Sensitizers of insulin, biguinides, TZDs, things that decrease absorption of glucose, dipeptidyl peptidase inhibitors, DPP-IV inhibitors, also incretin mimics, and then now the new kids on the block, the SGLT2 inhibitors. Let's go through each of these drugs and their caveats. Sulfonylureas increase insulin released by the beta cells. So one of the big side effects of these drugs is the fact that they can cause hypoglycemia. Now, the first, second, and third generations differ in their half-lives. First generations have very short half-lives. Second generation have a little longer half-lives. Third generation have the longest half-lives. Now, the beauty of this list is that all of these drugs have been discontinued except for 3 of them. So there's only 3 you really need to remember. And they are glipizide, goes by the trade name glucotrol, glyburide, and glimepiride. Those are the only 3 that are still on the market. The rest of them have been removed. Intense competition between these drugs drove some of them to extinction. The ones that work the best are those 3, glipizide, glyburide, and glimepiride. The initial work suggested that these drugs increased the risk of cardiovascular events. There was a very large trial called the Carolina trial, and then another trial called the Carmelina trial. Those trials showed that cardiovascular risks were no higher than placebo. All right, so the caveats about these drugs, number 1, because they increase the amount of insulin, they promote weight gain. They can also promote or induce hypoglycemia. This is particularly a risk in the elderly. Gastrointestinal effects can be mitigated by taking the drugs with food, and they tend to go away after the first few weeks of taking these drugs. So GI disturbances, even though they can really drive some people bananas, are really not such a big deal because they go away. Dermatological, they make you more susceptible to sunburn. So it's really important to know the signs and symptoms of hypoglycemia. So mild hypoglycemia would be 60 mg per deciliter or below. Usually with mild hypoglycemia, the patient will usually get pale, so pallor. would be one of the first signs. They'll have tachycardia. However, keep in mind, if they're on a beta blocker, the beta blocker will shield the tachycardia. So keep that in mind. Secondly, the patient will be shaky and they'll be hungry. They also might be irritable, although irritability takes different shapes in different people. So some people are irritable, but they're already ornery, so you don't really notice it. Other people, their idea of irritability will say, honey, can you please stop doing that? So it's going to vary. How do you deal with mild hypoglycemia? A half a cup of fruit juice, soda or milk can mitigate mild hypoglycemia. Also, there are glucose tablets. Those glucose tablets, sometimes diabetic patients will have those with them, and you can take usually 1 or 2 glucose tablets, and those will do the trick as well. What about moderate hypoglycemia? Now the blood sugar goes below 40 milligrams per deciliter. Now the patient will have an inability to concentrate. They'll be confused. Their speech will be slurred. You'll think that they're drunk sometimes. Their behavior just won't make any sense. They'll do things, you hear stories. I don't know if any of you know Amanda Bach. Amanda is a type 1 diabetic. She has some great stories when her blood sugar gets low. And of course, the stories always get better the way Amanda tells them. Amanda told me a story about she was hungry, so she went to the window and opened the window because she mistook the window for the pantry. She opened the window and started reaching out the window, trying to get some food. So sounds like a pretty dunderheaded thing to do. That's a low blood sugar sort of thing to do. The vision will blur. The reaction time slows, and there'll be extreme fatigue. So now what do you do? Again, juice. You want to give at least 15 milligrams of glucose. And 15 milligrams of glucose is usually in about 8 ounces of orange juice or 4 ounces of grape juice. But for moderate hypoglycemia, wait at least 30 minutes before they do any activity, because it'll take a while for the blood glucose to go up and be in that healthy level. If it gets really bad, they might need to go to the hospital and get IV glucose. Severe hypoglycemia, if the blood glucose goes below 20 milligrams per deciliter. Now you'll have very disoriented behavior, loss of consciousness, inability to arouse from sleep, seizures, coma, and if it's not treated, death. And the risk of hypoglycemia is highest in the elderly. So, your job, if you're a healthcare worker, is number 1, make sure the drug is taken as prescribed. Make sure the patient knows the name of the drug so that if a healthcare professional says, what medication are you on? They can say, I'm on glucotrol or glipizide or something like that. Make sure they know the dose. And they take the drug as indicated, make sure they know the indication. Make sure they can say it back to you, or they have written instructions that they can read to you. When an older patient becomes hypoglycemic, they're now at risk for falls. So they need to have rails. They need to hold on to those rails. If you're in a hospital and a patient's in a hospital bed, the bed can't be too high. Otherwise, they're going to get off the bed and go straight down. When they get up, they should have help. And when they walk, they should have the belt on, and you should be holding it. The falling belts, they're usually white. Okay, they're not white in all institutions, but in many places they're white. And if you see the white belt, you know that person's a falling risk. In some places they're black, I think. But they're big and they're thick, and someone has hold of the back. That's how you know that someone's a falling risk. Also emphasize, these pills are not insulin. They're not a substitute for diet and exercise, and they are not a cure. They are not a cure. They must continue to take them regularly. All right, let's talk now about metformin. Metformin is a mainstay treatment for type 2 diabetes. It goes by the trade name glucophage, but it's been generic and it's very cheap. Generic metformin, a month supply of generic metformin is $3.60. Very cheap. This drug does not cause hypoglycemia. This drug also allows patients to lose weight. Tends to work in the liver and peripheral tissues. It decreases glucose production by the liver, and it increases insulin sensitivity in skeletal muscle. The biggest complaint about this drug has to do with the GI issues, but metformin now is almost always prescribed in an extended release formulation. The extended release formulation greatly decreases GI complaints. Metformin must be taken with the first bite of food. You take it with the first bite of food. And if metformin is used in combination with a sulfonylurea, it tends to prevent the weight gain caused by sulfonylureas, because metformin tends to act as an appetite suppressant. In fact, metformin is used off-label for weight loss. Lactic acidosis is a rare side effect of metformin. Lactic acidosis is characterized by unusual muscle pains, very labored breathing, stomach pain, irregular heartbeat, weakness, dizziness, excessive fatigue, and a metallic taste in the mouth. Now, metformin must be used only in patients without renal disease and without hepatic disease. If you have renal disease, it increases your risk of lactic acidosis. Lactic acidosis is a medical emergency. there's a 50% mortality rate for people who experience lactic acidosis. If the patient gets GI effects, nausea, vomiting, diarrhea, that sort of thing, those will usually subside within a few weeks. The other issue that's not on here about metformin is that metformin can disrupt the absorption of vitamin B12 and folate. There are vitamins you can take with B12 and folate that you take sublingually. Celebrate Vitamins makes a quick melt vitamin formulation you put under your tongue and it melts. So you don't have to take it GI because metformin will change the way some things are absorbed. So because it affects absorption of those vitamins, that means you could be at risk for megaloblastic anemia. So by using supplements, particularly sublingual supplements of B12 and folate, you can decrease those risks. Oh, and incidentally, lactic acidosis is treated with hemodialysis. That's why you need to go to the hospital if you have it. Acarbose. Acarbose, also another drug, meglitol. Sorry, meglitol. I said meglitol and acarbose inhibit glucosidases found at the brush border that degrade oligosaccharides. Because they degrade, they prevent the degradation of oligosaccharides. They slow down the absorption of glucose. So now your blood sugar, instead of doing this, will tend to do this. That gives time for your medications to work. So this can reduce postprandial blood glucose. These drugs are always used in combination with other drugs. They're never used as a monotherapy. Big downside of these drugs is that those oligosaccharides are now fermented by bacteria in the GI tract. That fermentation produces a lot of gas and a lot of organic acids. That can produce cramping, flatulence, abdominal pain, and diarrhea. So monitor the impact on your patient, and if it gets quite bad, just discontinue the medication. Now, there is a product you can take over the counter called simethicone. Simethicone, I think the trade name of it is Gas-X. Simethicone does a very good job of relieving intestinal gas and pain from intestinal gas. Simethicone is a product that absorbs gas and prevents it from causing flatulence and gastric pain. The other issue with these drugs is that they can disrupt the absorption of iron. So you want to monitor hemoglobin and iron levels. Katya, how would you do that? CBC, complete blood count, because that'll give you the number of red cells, right? And then that same count will tell you how much hemoglobin is in each red blood cell. Is that not a measure of iron? Of course it is. Of course it is. So that's one of the other issues with this is the obstruction of iron absorption. So monitoring hemoglobin and iron levels, just do a CBC, complete blood count. That'll tell you whether or not your patient's getting enough iron. And again, it becomes a big issue, discontinue. Now, iron supplements, if you use iron supplements, oral iron supplements won't work because oral iron supplements need to be absorbed, and these prevent absorption. You'll have to use parenteral iron supplements in that case, or just discontinue the medicine. Right, because the oral supplements, their absorption will be affected as well. Finally, another risk of this drug is hepatotoxicity. Hepatotoxicity. So, monitor liver function tests. Those are those enzymes that you look for. You look for alanine transaminase and aspartate transaminase and bilirubin and albumin and stuff like that. Look for those levels. Those are called liver function tests, LFTs. If those are elevated, that tells you of liver damage. But the liver function will return to normal if the drug is discontinued, so it's not permanent. So that's just something else to watch as well. Contraindications. Don't give the drug if patient has inflammatory bowel disease. So if patient has ulcerative colitis or Crohn's disease, don't give it. Don't give it if people have renal insufficiency. Don't give it if they have some other chronic intestinal disease. And don't give it to people with cirrhosis or diabetic ketoacidosis. Okay, the thiazolidinediones, which we're going to call TZDs. There's two drugs here, rosiglitazone and pioglitazone, which go by the trade names of Andia and Actos. These drugs, again, they increase peripheral tissue sensitivity to insulin. These drugs, unfortunately, cause you to gain weight. These drugs will also raise LDL, and they also cause fluid retention. Because they cause fluid retention, they can cause pressure on the heart. Pioglitazone, Actos, well, rosiglitazone too, has a black box warning for liver damage. It's also clear if you use these drugs long term, they can increase your risk of osteoporosis. So these drugs monitor for edema. Where do you monitor for edema? Ankles. Ankles. Grab the ankle. If a imprint of your hand remains, that's called pitting edema. That's fluid retention. Ankles. Monitor for weight gain and for liver function. Monitor cholesterol levels. And it's a good idea before the patient goes on the drug to get a baseline liver function. That way you have something to compare it to. Also, if the patient has any sign of liver function, if their whites of their eyes start to yellow at all, or if their urine gets really dark, that's probably a sign of liver function. They should contact their doctor immediately. Okay, some newer strategies. We have the DPP-IV inhibitors and the incretin mimics. Incretin, so GIP, glucose-dependent insulinotropic peptide, GIP, and glucagon-like peptide, those are incretins. They prime the pancreas to receive that blood glucose that increases your insulin release. These also have a trophic effect on the beta cells. That trophic effect prevents the beta cells from becoming exhausted. There are small molecules that mimic the activity of these. Those are largely injected. And then you have inhibitors of dipeptidyl peptidase 4. They cause your own incretins to have a longer half-life. Both of these are drugs that are used to treat type 2 diabetes. So first there are drugs that end in gliptin, saxagliptin, alogliptin, linagliptin, sitagliptin. What are the caveats with these drugs? Very few. These drugs are on the average very well tolerated. So when you look at the side effects, notice, first of all, pretty small potatoes here with numbers. Also, there are things that just really aren't that big a deal. Headache, well, I'm sure for people who have headaches, it's a big deal, but headache when it comes to side effects in 4% of people, when your placebo has 2%, not a big deal. Stuffy nose, stuff like that, pretty small potatoes. On the average, the side effects are very nonspecific and very general. On the average, these drugs are quite well tolerated. They don't tend to cause hypoglycemia. You can lose weight on these drugs as well. Incretins. So the granddaddy of the incretins is exenatide. Exenatide is taken twice a day, once before the first meal of the day, second time before the last meal of the day. Liraglutide is taken once a day, regardless of when you eat. So that is a convenience for liraglutide. Now, these drugs delay emptying of the stomach. Because they delay emptying of the stomach, they increase satiety. Because they increase satiety, you lose weight on these drugs. In fact, in some cases, you lose a lot of weight on these drugs. And liraglutide has now been FDA approved as a weight loss drug. So some people are prescribed liraglutide for weight loss. These drugs are taken every day. There is a form of exenatide now that lasts longer. You only take it once a day. But there are long half-life incretins. These you only take once a week. Dulaglutide, abiglutide, semaglutide, and what have you. You just take these once a week. Semaglutide now comes in an oral form called Rybelsus. That's the first oral incretin mimic. And these drugs essentially now have really taken diabetic treatment by storm. The research on them is quite impressive. They can drop your A1C by 2-3% sometimes. So the big side effect you see in most people with these drugs when you first get on them are GI symptoms. Nausea, vomiting, diarrhea, things like that. Those will tend to decrease as you take the drug and get used to it. The other issue, which is rarer, is pancreatitis. Pancreatitis occurs in about 1.7 to 0.7 cases per 1,000 people. Not very frequent. In this case, you have severe, intolerable midsection pain, upper epigastric pain. You must notify your doctor immediately when those symptoms become intolerable. These drugs are pregnancy class C, so they're not recommended with pregnant women. They're also contraindicated to people with kidney disease, an irritable bowel, inflammatory bowel disease, or anyone with a history of pancreatitis, then they should be used with caution in people who have thyroid disease. This just comes from clinical trials where you compare these drugs head to head and what have you, and it just shows you they all reduce glucose quite well. Some of the long-term ones tend to reduce it extremely well. And the change in weight is substantial in some of these. Okay, SGLT2 inhibitors. These work in the kidney. They decrease the uptake of glucose and sodium and therefore water. So the big side effect will be increased urination. You also have increased thirst, and you may also have dry mouth and then constipation as well. You can allay that by drinking more and by including more fiber in your diet. Allergies have been reported. There's also, particularly in women, an increased risk of urinary tract infections. And there's also black box warning about kidney failure. Having said that, several large clinical studies have now shown that these drugs decrease the risk of cardiovascular events, decrease the risk of diabetic nephropathy, and decrease the risk of hospitalization and death. So these drugs have really proven their mettle. Notice that these drugs end in glyphosine. Glyphosine. When combined with other drugs, particularly metformin, these drugs can drop glucose like a rock. In many patients, whose glucose just can't get in the normal range, really get a normal glucose reading when they get on these drugs. All right, we will end there. We'll talk about insulin therapy next time, talk about calculating insulin dosage, and then that should be it.